Myself. My name is Dr. Jay Brownbottom from Harborview Medical Center, and I am your co-host this lovely morning. Thank you to Dr. Goulet for getting us going. Um, Two more presentations for the day. I want to introduce our first speaker of the second half, Dr. Catherine Bowles, who's going to be talking about rapid responses and the interface between acute care and critical care medicine. Dr. Bowles is a hospitalist practicing in Seattle, Washington, at Harborview Medical Center. She specializes in the comprehensive medical care of our wonderful hospitalized patients at Harborview, where I'm one of her colleagues. Dr. Bowles is very intimately involved in a lot of QI efforts at Harborview Medical Center, and one of her major projects over the past few years has been the collaboration between the acute care and ICU folks, looking at how to best optimize our rapid response practices at our hospital. With that, thank you so much for being here, Dr. Bowles. I'll turn it over to you. And folks, as usual, the Q&A button is available for you. I'll be monitoring that in the chat during this presentation. If you have any questions, please leave it there for us. Thank you.
Wonderful. Thank you, Jay, for that wonderful introduction. So as Jay said, I'm Catherine Bowles. I work a lot in our rapid response infrastructure, both frankly as a provider who works a lot with rapid responses and acute care patients, and on the system side. And I think rapid responses are really interesting because they're where our work as hospitalists comes together with our colleagues in intensive care to help patients who are rapidly decompensating. And I want us to look at how we can improve that process for everybody involved. So I want us to work on defining what a rapid response actually is, what it's meant to address, and how it does at addressing those issues. To assess some challenges in rapid responses, I know probably everybody's thinking of some. And how do we identify and respond to decompensation? How do we work as a team to respond? And how can we as providers, leaders, and systems respond to these challenges to better help our patients? I don't have any disclosures. If anybody wants to pay me more for this work, my email will be at the end, and I'm happily soliciting offers. So we're going to talk about issues at the bedside, but we're also going to talk about these on a larger scale. And I know sometimes this can feel really detached and really technical, but it isn't. Yes, this is systems and quality improvement, but these systems have a huge impact on our experiences and those of our patients. I want you to think about the last decompensating patient that you saw in acute care. What went well? What went poorly? And how did the systems or the rapid response team serve you and your patient? And how did they fail you? I recently saw a middle-aged man who had just suddenly was bleeding profusely from IV sites, from epistaxis, and had a rapidly increasing oxygen requirement. The primary nurse did a great job of identifying that he was significantly worsening and got us and got the nurse and its stat nurse to bedside. We started them on a non-rebreather. We started interventions for the bleeding. We got labs rapidly, and we reached out to ICU because it was pretty clear that we weren't going to be able to care for them on the acute care floor. The patient transferred fairly rapidly for their escalated needs and ongoing treatment, and ultimately actually was stabilized, transferred back, and last I looked had actually discharged successfully from the hospital. But there was still confusion, even in this relatively good rapid, on contrasting orders and kind of patient ownership during transfer. And there had been major issues the day before with new increased intracranial pressure that was symptomatic, where there were rapids and specialist assessment and ICU assessment, and yet there was no clear conclusion and no clear guidance despite hours and hours of rapid and intervention. And this patient did still end up requiring additional monitoring, imaging, and treatment for both of these causes of rapid on the floor and while in the ICU. So it's worth us thinking about, how did this care go well and how can it improve? So I want us to step back a little bit and think about, what is a rapid response? Rapid response is a system, not only a team. We're seeking to address in-hospital medical emergencies. When a patient's already here and they're deteriorating to the point that there's imminent risk of serious harm. And this really is a matter of trying to match the resources to their needs. Often, these are critical care resources, but they're not always. And we want to match that regardless of where the patient is in the hospital. There's lots of forms and lots of names. You might see studies or hear things that call this a medical emergency team or a critical care outreach team. And there's a lot of different team compositions for this as well. Usually, a good rapid response should have 4 primary components. So that includes an afferent component where you work to detect decompensation and trigger the actual response. This is actually often the most challenging arm to design, and we'll talk more about that. There's also an efferent arm, which is the response itself. Who are you going to call? What's the team composition? What are the abilities of the team members? What are the resources they have available? And what are the potential transfers or escalations they have available to them? And patient safety or process improvement arm. I work a lot on this, so allowing for review of cases, trying to assess where strengths and weaknesses lie and where there might have been fallouts or major issues, and revision of the full system as necessary. And then there's a governance or administration arm, which is, it's where the money is. It's who provides resources and staff and determines how you're going to use them and what appropriate utilization really looks like. So why do we do this? Part of this is a gut check. If patients are going downhill, we should mobilize resources to stop that. But unfortunately, as we all know, gut checks don't always make hospital policy. So how do we end up with this specific form? So the first major area we see this in is actually in 2005 in the Institute for Healthcare Improvement 100,000 Lives campaign, which was put together with a goal of saving 100,000 lives in 18 months. What you see here is not only a plank of the campaign, but was actually the very first listed plank to try to deploy rapid response teams to better rescue patients who would otherwise have in-hospital cardiac arrest, decompensation, or death in the hospital. Subsequently, in 2008, the Joint Commission put in their national patient safety goals, the goal that you see here, which sounds an awful lot like that definition we just saw of a rapid response system. Trying to call the right person and have a specially trained individual to call when the patient's condition appears to be worsening to prevent that from worsening further. And as we all know, once the Joint Commission says it, there's associated expectations for standards of compliance, for research, and for development. And that's going to lead to much more systemic uptake. So now we know the history of why we use a rapid response system. But what's the actual data on their actual efficacy at preventing adverse outcomes? So let's talk first cardiac arrest. Most studies and meta-analyses show an improvement in rates of in-hospital cardiac arrest with rapid response system use. The data you're seeing here is Solomon et al., which is a meta-analysis of 30 studies. You're not seeing 30 there because in a theme you'll find in a lot of the rapid response data, not all of them reported the same sets of data. But overall, use of rapid response teams led to a significant decrease in the number of non-ICU cardiac arrests with a relative risk of 0.62. A similar study, Zhang et al. In 2024, showed that about 60% of studies had a decrease in in-hospital cardiac arrest, while the remainder didn't have a clear impact. I'd say that overall, especially in a pragmatic setting, this is actually pretty strong data, even though it's very messy. Those are some big error bars you're seeing. There's lots of different study designs, different qualities of the study, and different interventions that they're actually studying when they look at rapid response. And it's worth noting there's actually differing definitions of cardiac arrest around these studies, whether that's hospital-wide or just non-ICU, whether that's pulselessness, respiratory arrest, or just code blues, which may not actually qualify for the first two. And that complicates intervention a lot. And we'll talk more about this later, But some studies actually had ineffectual or extremely late interventions, where once you look at the deeper into the study, it's not surprising that there wasn't much change. So we'll talk more about that later. What about mortality overall? It does look like there's an improvement, but it's not as strong as there is for cardiac arrest. Again, Solomon et al. Had a relative risk of 0.88 for mortality overall. And Zhang et al., the newer meta-analysis, showed that half of articles showed a reduction in hospital mortality, and the remainder didn't show a clear effect. Multiple other studies do seem to show a dose dependency, so there's actually better outcomes when there's more rapid responses, and a timing dependency with significantly higher mortality when there are activation delays in rapid response. And Zhang et al. Actually commented that they thought the inconsistent outcomes in mortality were likely primarily due to underutilization and delay in rapid response, as well as some multifactorial components in mortality, including patient characteristics, hospital level, staffing, and because that newer study also included COVID, pandemic, and all the wonders that the pandemic brought. It also actually seems like pre-COVID, a lot of the studies were underpowered because they actually had lower unexpected death rates than they were expecting. So it's just more difficult to analyze some of those earlier studies because they didn't have the power they thought they would. So what about things that aren't just death? As far as ICU transfers go, the impact is really unclear. We already said that not all the studies were even impacting mortality or cardiac arrest. Only around a third of them report on ICU admission rates at all. And there's push and pull factors here that are probably simultaneously active. So more rapid responses, you're likely to identify more decompensation and might actually identify more patients that need ICU transfer. So hopefully they're all patients that would need ICU transfer anyway. But you're also hopefully getting in early on more patients and being able to do effective interventions on acute care that can prevent need for ICU. It's also worth noting that there's lots of other factors that impact ICU transfer, and often those are institution specific. So things like the presence of a step down or intermediate care unit is going to be a big impact. It's also sensitive to census ICU capacity. What are the criteria and what are the nursing ratios that are available to you on the floor? What about our administration's absolute favorite metric, length of stay? Even fewer studies comment on this whatsoever. And there's variable impact, but it seems like there's probably no impact at all. I know I'm preaching to the choir. There's a lot of different factors that impact length of stay, patient acuity being one of very, very many. And many of these factors aren't actually controllable by the patient, by us as providers, and maybe not even by the hospital at all. So it's not super surprising there's not an impact here. So I want to take us back to that initial definition. A rapid response is a system to quickly address clinical decompensation that aims to prevent progressive deterioration, ICU transfer, cardiac arrest, or death. But what is clinical decompensation? This is harder to define than we think. You probably have something that's bouncing around in your head. And to quote Supreme Court Justice Potter Stewart, when he was asked to describe his test for obscenity, I know it when I see it. But can you systematize that gestalt? This might actually be different at different sites due to variations in acute care floor capabilities, variations in step downs or IMCUs, staffing, resources, and whether they're a training or a teaching hospital. And I'm not going to comment too much on this, but some of you probably work at rural sites or critical access hospitals where there might not be an ICU or there might not be a cath lab, so transfer out might be required. You're going to have a very different definition of clinical decompensation when you have to think about a half-hour ambulance trip to get to the nearest large hospital. So thank you to many friends that helped contribute to this, but I worked on trying to figure out what are the ways our local systems know it when they see it. So they actually use a wide variety of different criteria. And I think it's worth us looking down the left side here Staff concern, vital sign abnormalities, chest pain, respiratory distress. None of these seem unreasonable, right? But if you look across, there's actually a lot that are different between these different systems. Not all of them actually use specific vital sign ranges. I noticed these seem a little more prominent in some of our teaching sites. And some of them actually rely primarily on subjective symptoms. And it seemed to me like that actually was a little bit more common in some of our hospitals where they have highly variable acute care resources. They might actually be policies that apply to a whole group of hospitals. None of these, again, are critical access. They're all relatively large tertiary or quaternary hospitals and systems in an urban environment. So again, this may not apply to you at all if you're in a rural setting. But I want to have us start looking actually at these specific vital signs, because while not all of our local hospitals use them, they are the most common trigger across the board for rapid response and for us identifying decompensation. So when I say the most common trigger, I mean what we call single criteria vital signs. So if you meet NRT criteria, you have a heart rate of 140, a rapid response is called. Unfortunately, studies show that there's highly variable, but overall low sensitivity, 7 to 54% across a couple of studies, and low positive predictive value, 14 to 26% of criteria like this in predicting in-hospital mortality. Of the vital signs overall, the respiratory signs, particularly tachypnea, are most predictive of cardiac arrest across multiple studies. With some studies showing a respiratory rate greater than 27 had a sensitivity of 25 to 54% and a specificity of 83 to 96%, and a respiratory rate greater than 35 having an odds ratio of 31 for predicting cardiac arrest. Need for non-rebreather or need for 100% FiO2 also are very sensitive and specific for showing that you may have a high risk of subsequent cardiac arrest, as is hypotension, specifically low diastolic pressure and high pulse pressure, and significant tachycardia. I think it's worth noting here that one of the major issues with some of these systems is I think a lot of us are really used to seeing systems that involve a lot of systolic use. And systolic blood pressure actually performs a lot worse than diastolic blood pressure or pulse pressure at predicting cardiac arrest. And there's not a clear association between high blood pressures and arrest, even though most systems are using systolics rather than diastolics and have both low and high bounds. And then unfortunately, these systems are difficult to balance. Global modifications, so adjusting sort of where your criteria lie for all comers, seem unable across several studies to significantly impact sensitivity or positive predictive value of these systems. They can have huge impacts on the workload and the false positive rate, with one study showing that a potential number of calls changed from 234 in a month to 3,271 in a month, depending on which criteria were chosen. So what about this criteria we actually saw across the board in our local systems? Staff concern. So staff concern or subjective worry often comprises a variety of systems-based and intuitive measures. Things like changing in breathing and circulation, altered mentation, pain, not really responding well to treatment, or just general intuition that something's off. It does not appear especially predictive of cardiac arrest or mortality on its own. And if you just take all worried calls, they seem to have a cardiac arrest as a less common potential outcome. But when studies combine subjective worry alongside objective signs or early warning systems, they actually find that they perform better than the traditional early warning systems overall. And they increase both the sensitivity and the positive predictive value, as well as reducing the number of false positives. Notably, and it probably makes sense to you that this is true, the most predictive areas are going to be your cardiac or respiratory decompensations that aren't meeting specific vital sign criteria yet, but are still pretty bad. Think about your patient who's got really bad work of breathing, but technically speaking, their vital signs haven't worsened yet in a way that would actually trigger a rapid response. And it's also worth noting that there's actually more calls for subjective worries at hospitals that have a robust rapid response system overall, which is thought to reflect that there's less fear of calling. And the idea is that these systems may actually benefit from this additional sensitivity that these worried calls bring. So what can go wrong with these systems? I know you've got something in your head. Let's talk about the actual stats. So when we actually look through the studies, there are significant activation delays. And here I mean 1 hour or more from the time when there was actually a documented rapid response trigger, whether that was an early warning system, whether that was subjective worry, whether that was a vital sign, and an actual rapid response being called in a quarter to over half of studies of patients in multiple studies. This is more common at night, and it's associated with significantly higher mortality. I also alluded earlier to the idea that some of the negative trials are less surprising when you dig into the data. The largest randomized control trial of rapid responses, called the MERIT trial, is often cited as a negative trial of rapid responses, as patients across that trial did not show a significant improvement. But when you dig in, most patients were identified less than 15 minutes before they had a cardiac arrest, death, or an ICU transfer, if they were identified at all. If you actually look at their data, the criteria they used didn't even identify 75% of the patients who went on to have one of those events. And another study showed that 25 patients who had an in-hospital cardiac arrest met rapid response criteria 0 to 8 hours prior to their arrest, and no rapid response was called. So we got pretty clear, pretty substantial delays. So why do we have these? One big area is a lack of experience. We know that we have a lack of experience across many levels of hospital medicine, whether that's our trainees, our providers, or our nurses. And that can lead to people seeking support to validate clinical decisions, seeking informal escalation, and clearly is associated in multiple studies with delays in activation. The way we actually divide labor may have a major impact here too. Our vital signs are often obtained in different systems by aides or by medical assistants who may not actually have knowledge or authority to evaluate or identify deterioration. And there might even be significant delays before a nurse is even notified of those vitals at all. Many nurses also report experiences of irritation, reprimand, or criticism regarding quote unquote invalid calls that leads them to have significant anxiety about calling and then having delays in calling. And this is true across multiple systems. This is one of the things where we can impact this not just as systems, but as individuals. We should really try to remember this in our practice when we are responding to these calls, as irritation or discouragement can lead to reluctance to call, and that can actually impair the whole system if this person is afraid to call subsequently. There are ways to give professional and thoughtful feedback, and we'll talk more about it, and that can help providers better target while not discouraging calls and impairing the ability of this system to work overall. And there's some issues with lack of monitoring on acute care. Multiple studies actually show that there's an increase of calls at nursing and provider rounding times and at morning nursing handoff, which is really suggestive of under-monitoring between nursing rounding times. It's also worth noting that this effect is actually less prominent in floors that have higher levels of baseline monitoring, such as a telemetry or teleoximetry floor, and that it's actually not really apparent in intensive care units at all. Pardon me. So what about census stress? It's not really a problem for anybody, right? There's plenty of empty beds across the community, across the country. So our wonderful sense of stress and bed availability issues can lead to admissions to non-ideal units or sites, since I don't know if we can even really call a hallway a unit. And that can make inadequate care and monitoring and clinical decompensation significantly more likely. We know this person needed particular resources and we didn't have them to give. I put ER boarding in this category as well. This really high workload on a lot of our providers, on a lot of our nurses, can lead to kind of some push and pull. It can lead to a lower threshold to call for assistance, but it can also lead to an increased workload that decreases the ability to identify decompensation, that it decreases the ability to monitor, as we just discussed. Events can cluster, and there's actually some studies that show that care diversion to one patient who's requiring a lot of level of care can actually lead to increased decompensation in other patients on the same ward in kind of the same period or subsequent periods right afterward. And then high ICU admissions and inflow can really significantly stress our ICU bed availability and our ICU team's capacity. And it can lead to inappropriate downgrading, with rates of unplanned ICU readmissions more than doubling when there's high ICU inflow, at least in the one study defined as greater than 10 admissions in 24 hours. So I think it's also worth us considering that there's lots of different mental models of what a rapid response is, what it's for, and what the possible outcomes are. And you can see some of these different perspectives in some of the interviews I did here. These different models can lead to some us versus them narratives that you're seeing here. A cry for help, an attempt to match up even if things don't fit, a pop-off valve. That can lead to a lot of conflict and tension. And that's not just true in our own lives, that's true in the study data as well. A rapid response can be seen as a pathway to additional resources, things like vascular access, labs, or imaging, whether or not these patients are actually experiencing decompensation. This can serve as a stopgap, especially when we're having issues with the system overall, but it diverts resources away from the actual purpose of a rapid response in addressing decompensation and can impair the ability of a rapid response itself to do its primary job. There are also issues where rapid response as a pathway to ICU transfer can cause a lot of conflict. There are different perceptions between ICU and acute care providers, but there were a lot of ICU providers that brought up a feeling that there's nobody looking to fix a patient. They just want to have a patient move. And there's also a lot of perception, as you can see kind of in the bottom corner here, that sometimes ICU and acute care standards don't really match up, and they may have areas where there's just somebody who falls in between the two. And so there might be issues where you can't make something work on acute care and you're perceiving an issue with delays to intensive care that may not feel fair to you either. And then there's a lot of conflict. These are high acuity, high stress situations. And in most other industries, these are areas where you'd have a specific team that goes in and addresses it, that knows each other really well. For us, we usually have an ad hoc team, and they may not actually be familiar with one another whatsoever. Conflict is very common, and multiple studies show that it undermines teamwork and efficacy and morale, and it can lead to all of us burning out. We probably can all think of issues and areas where this kind of led to us burning out or being not really excited to go to work the next day. When you look across these interview responses, you see major themes of disrespect, of not feeling listened to, of a lack of collaboration, a lack of leadership, and significant mistrust. So now what? We need to help our patients when they decompensate. Rapid responses are complex, they're resource intensive. The data do show that they probably help, but we want to care for our patients the right time, the right place, the right care, We want to work well with our intensive care colleagues to do it. So how can we improve it? What's on our to-do list? Well, we want to try and better identify decompensation. We want to reduce our delays in activating the system. We want to improve our flexibility and adaptability. And we want to decrease conflict and confusion where we can. So let's first look at better identifying decompensation. So aggregate scores or early warning systems overall have better specificity and sensitivity than single vital sign systems that we talked about before. So this particular graph compares those single vital sign systems that you're seeing in gray to one such score. This one happens to be the National Early Warning Score that they use in the UK. And it shows that the true positive rate, the sensitivity, over the false positive rate, which is 1 minus specificity at various thresholds. This is called a receiver operating characteristic. The idea here is that your upper left corner is a better system and your lower right corner is a worse system. And this trend shows that overall your early warning system is performing better. It's more sensitive while having a lower false positive rate. And this is not specific to the National Early Warning Score. This seems to be true across all the different early warning systems. They also seem to be more accurate in predicting in-hospital cardiac arrest, unexpected ICU admission, and complications overall. So not just mortality as a large statistic. But while it's worth noting they're more useful in predicting these systems, if you just adopt the score alone and you don't change anything else, they don't improve these metrics when they're used on their own. Aggregate early warning system scores also seem to have better efficiency. Rapid responses involve mobilizing a lot of staff and a lot of resources, so we really want to make sure they're targeted well. So aggregate scores do a better job of workup to detection. In this particular case, the closer the score is and the graph is the bottom right corner, the better. Indicative of a system that is identifying patients who are getting sicker, having high sensitivity, while not identifying so many patients that you can't possibly care for them or having too many false positives. This is a system that needs to evaluate fewer patients to achieve similar sensitivity. And as you can see here, Muse and News, which are two of the largest early warning scores, have pretty good workup to detection ratios. They're getting closer and closer to that bottom right corner. And you're going to see a lot of these different systems that are aggregate scores. There's significant debate over which is most useful. And as far as I'm concerned, looking through the data, the jury is currently out, particularly given that there's actually some pretty poor methods clouding some of the initial studies and calibrations that are comparing these systems. And all of them do struggle some with missing or incomplete data because they are aggregate rather than systems that allow you to just put in a single point. There are some studies that seem to indicate that a newer score called the Cardiac Arrest Risk Triage Score may be more accurate than some traditional early warning systems and a lot more accurate than those single vital sign scores. And there's some other systems that show promise in using machine learning and artificial intelligence to create tailored scoring systems for a particular institution's patient mix. However, the latter in particular can be really difficult to implement. They require a lot more data entry and a lot more money up front because you have to be able to design your own system. And you're usually going to require a computer for full use and analysis. So there's some really significant potential benefits here, but some of those more complex systems may need a little bit of work before they're kind of ready for prime time. So what about those big, long delays? Well, one solution might be to try and automate parts of the system. So there's actually some studies that have automatic activation, and I can kind of internally hear everybody clenching up at this idea. But this automatic activation after data entry and directly even sometimes from vital sign machines themselves. Most of these systems actually have a stat nurse or an ICU nurse reviewing the automated activations before they are progressed. which is the way that they avoid having this just go off constantly and just be another contributor to our alarm fatigue. These studies actually showed that while you did increase your rapid response activation, you improved your mortality, your ICU mortality, and your ICU length of stay. And these systems do seem to decrease the percentage of RRTs that actually require MD involvement, since they actually had tiers, and some rapid responses just had a trained nurse go to the bedside. And there were more cases overall that were manageable with advice or overall kind of acute care level interventions, suggestive of systems where, they may have actually been able to catch things early enough to prevent progression overall. There were false alarms, and most of them were actually due to human error in data entry, the same false alarm you're going to get if you're just doing a single vital sign system. But it was actually notable that because these systems had this aspect of automation, it seemed to encourage more rectification of the data problems than you see in some of the other systems. With some of the studies noting that while it wasn't an area they were studying, there seemed to be overall a lower rate of erroneous data entry as they progressed, probably because there was much more rapid feedback when there were errors. What about making systems that adapt better when we do have issues? So we talked a little bit about tiering a system to allow for things like automation and early detection. But tiering can also allow for better targeting of specific resources. We talked a little bit about the idea that sometimes one of the conflicts in rapid response is that people are seeking them to kind of solve a lot of different problems. And adding additional tiers, whether to the rapid response system or targeted deployment overall, can allow for better targeting of resources in both emergent and non-emergent situations. So having a devoted vascular access team, ideally one that can provide not just a peripheral IV or a PICC line, but can do ultrasound guided IV or can do a central line if needed. We also at Harborview have actually initiated what's called our Ask Nurse role, which we primarily do at night, which allows for a more experienced nurse to be available at night when we have more of our nursing colleagues who have lower levels of experience, so that they have somebody they can ask and they can work with without necessarily needing to call a rapid response, because they may have issues that are very concerning to them that are not necessarily clear clinical decompensation. And it might even help them to sort out which ones are. At Harborview, we've also been working on using revision, so permitting individual changes after attending review. We talked about the idea that revising entire systems, unfortunately, doesn't seem to work very well to improve sensitivity and specificity. This is the idea that we can use our critical appraisal and individualized care to revise our vital sign criteria. We use a single criteria system, much to my chagrin, to allow kind of for patients with chronic tachycardia that doesn't appear to note decompensation to be kind of opted out of some of the traditional criteria we use. And we've had good experiences thus far, though I don't have specific data to show you on that. There is minimal literature evidence on criteria revision, so it's hard to recommend that overall, because we just don't have a lot of evidence to go with. It is worth noting that all of these kind of early adaptations we've been talking about do need to have governance and feedback systems reviewing and responding, and they should not really be happening in isolation. They're unlikely to be very effective in isolation without some of the other changes together, or if they're in isolation and the system is still so utterly overloaded from census that you can't effectively respond. And we're not going to talk too much about census here because that's a way bigger topic, but I do think it's worth noting that none of the systems will work as well until that workload goes down. So what about that last huge issue of conflict and communication? So we actually have seen that teamwork training, such as Team Steps with our lovely logo there, focuses on ensuring that all parties are heard, not just those at the peak of a hierarchy, and that we efficiently and respectfully attain information from all party members, with the idea that like you may actually have a fair amount of information as the doc, but your bedside nurse might have a lot, your respiratory therapist may have a lot. And getting all of that information, not just what you have to bring to the table, is really important in these kind of critical situations. It also helps ensure that interventions are undertaken quickly. It's worth noting that this is not just everyone sitting around and singing Kumbaya. These are structured interventions. People may be familiar with the idea of the two challenge rule or the CUS framework. These are specific frameworks of how we talk with one another and work in these critical situations that actually have shown efficacy in improving safety metrics, in improving levels of conflict, in some surgical safety settings, and improving culture of safety overall, and perceptions of teamwork. And for those of us who work in teaching settings, it's also worth us thinking about how do we teach handling these situations. We often focus on the clinical side, and that's super important. But we should also think about how do we teach these as a situation to work through. So setting basic expectations for assessment, communications, interventions, expert consultation, documentation, and follow-up, with the idea that this should be a structured thing, not an ad hoc thing we make up every time. One study by Jones suggested an A to G framework, where we teach trainees to ask and assess, to begin basic investigations and resuscitation, call for help if needed, discuss, decide, and document, to be able to explain etiology and management choices, to follow up, and to graciously thank our staff. And while all of these might seem a little corny and a little silly, these kinds of interventions that promote just culture and promote kind of everybody stepping back, thinking and communicating in a structured way do seem to have real measurable effects. So in conclusion, our rapid responses are a system to bridge acute and intensive care, quickly addressing clinical decompensation and trying to prevent progressive deterioration. Our data appear to show benefits in mortality and in-hospital cardiac arrest, but they're really messy due to a variety of definitions, due to different systems, due to different confounders. Clinical decompensation is a lot tougher to define. We know it when we see it, but more comprehensive and tailored scores and use of aggregate scores where we can seem to improve sensitivity and efficacy, and revision might allow us to have some individualized tailoring that may be really useful here. Delays, high census, and conflict really undermine the efficacy of rapid response. And it's worth us considering things like a trial of automation with a tiered system that might help with our overall delay rate. Trying things like team-based training and structured teaching to help reduce conflict. And continuing to work with our governance and administrative systems on high census. And it's worth also noting that different environments might need different systems. So knowing that our graph of all those different RRT criteria was different, even all these quaternary systems, but that you as a worker in some other site may actually need a very different system here. So using a site and a flexibility and having a system that is flexible and adaptive to what you need in your particular system is going to be extremely important. So thank you for listening. If you scan the QR code, you should get my references. My email is there, and I'd love to take any questions that anyone may have.
Thank you so much, Dr. Bowles. Put a lot of effort into reaching out to a lot of institutions. There's one question kind of that I had regarding in your experiences talking to folks from these different institutions. Did you find any particular structures, formats, templates that you found to be particularly either efficacious or creative when managing these rapid responses, or either at a team level or an institution level?
And I guess when you ask that, do you mean a team composition or like a communication method or like
Yeah, anything that you found particularly creative that could be replicated at other places.
I think one of the issues with replication was actually that there were people that sort of reported better and worse interactions overall. And I can say that some of the teams where it seemed like there was a lot of conflict and there was a lot of perceived inflexibility, usually both from an intensive care and an acute care side, had much higher levels of conflict overall. While some of the settings reported much lower levels of conflict or burnout, but the structure of the setting is so different. Often having a step down did seem to reduce some of the conflict around these because it gave a kind of pop off valve where there's places for some of the patients that don't clearly meet either ICU or intensive care criteria. Did seem like it reduced the overall levels of conflict. And one thing that was notably seemed to be common was whether it was having an all attending level system, so a community system where everybody involved is kind of at the highest level, or a system where attendings or someone else who has experience can come to bedside rapidly, did seem overall to reduce the level of conflict. Partially, I think, because there was less confusion about who's leading a rapid response and what's going on there. Because one of the main issues that did come up uh, sorry, as you go back through some of these interviews, was this lack of clarity on what's the decision process, where is somebody going, what's going to happen for this patient, was a major cause of conflict. And it did seem like having kind of experienced providers um, was a really important component of that. I don't know if that answered your question. There was not a clear, unfortunate, like one size fits all thing. It seemed like it was often very dependent on the style of hospital and what their particular resources were.
Great. No, that was very interesting. Thank you for sharing all of this. Give folks another few minutes if there are any other questions. And if not, we'll take a break in just a little bit. Dr. Bowles, are you able to go back to your conclusion slide?
Yes. And I guess I can also note a little bit of what you were asking about, but um, there are very different team compositions, both in studies and in our local teams, but there's not clear data on a particular team composition that appears effective. So um, there's ICU led, acute care led, nursing led, and provider led teams across the different systems, and there's not a lot of clear impact. And our systems in particular, you can actually note that while all of them have kind of some nursing component, actually not all of them have a MD component at all. And that didn't, at least in my interviews, seem associated with clear kind of trends in one direction or another.